webinar with other folks in your organizations and communities. We will be having a question and answer session at the end of the webinar. And again, I will provide instructions for how to enter questions in the question box at the end. And then last but not least, I wanted to just note that this webinar is off the record and closed to the media. And so if you are representing a media organization, this is, we ask that you not report on this webinar and use this for background and educational purposes only. So with that, just wanted to introduce and provide some background on today's webinar. So as you know, hepatitis B is the most common serious liver infection and can lead to liver cancer. Asian Americans, Native Hawaiians, and other Pacific Islanders are particularly impacted by this disease, and more than half of the estimated hepatitis B carriers in the U.S. are Asian American, Native Hawaiian, and Pacific Islanders. Therefore, it is critical that Asian Americans and Native Hawaiian and Pacific Islander individuals are screened and vaccinated for hepatitis B. However, community-based and national approaches are also needed. So for today's webinar, we hope to provide an overview of hepatitis B and its impact on our communities. The speakers today will discuss strategies for eliminating new infections through community-based partnerships and through passage of H.R. 3974, the first federal legislation introduced to address viral hepatitis and liver cancer prevention. All participants will have an opportunity to learn, engage, and ask questions at the end, and everyone is encouraged to submit questions. So today's agenda will include a Hepatitis B 101, which will be presented by Karina Dan. She will talk about what is hepatitis B, how it works, and what the impact has been on Asian American, Native Hawaiian, and Pacific Islander communities. Next, we'll hear from Doug Hirano, who will spotlight some of the community-based responses that his organization has been a part of. Next, we'll hear from Bernadette Ariella, who's with Congressman Honda's office, and she will provide an overview of a federal response, which is the legislation I mentioned earlier, H.R. 3974. We have a really great lineup of panelists today, and just to say a few words about their background, Karina Dan is currently the Hepatitis B Policy Fellow at the at the Association of Asian Pacific Community Health Organizations in Washington, D.C., where her duties include education of legislators and their staff, community consensus and capacity building, and developing materials and presentations on hepatitis advocacy and policy. She is incredibly accomplished, and her accomplishments include being the former Chief Operating Officer of the Hepatitis Foundation International. She was also the Adult Viral Hepatitis Prevention Coordinator for the City of Chicago, where she developed a citywide hepatitis program under a cooperative agreement with the CDC Division of Viral Hepatitis. She was a community health nurse and is a registered nurse, as you can see. And so we're really fortunate to have Karina here on the webinar to provide an overview and to share some of her insights on this issue. Doug Hirano is the Executive Director of Asian Pacific Community in Action, which is based in Phoenix, Arizona. He's been in that position since July of 2006 and has worked for 14 years with the Arizona Department of Health Services in various program areas, including HIV, AIDS, and primary care. He is a past president of the Arizona Public Health Association and current chair of the Maricopa Integrated Health Systems Family Health Center Governing Council and Community Advisory Board of the ASU Southwest Interdisciplinary Research Center. And last but not least, we have Bernadette Ariella, who is not a building, but works in the U.S. Capitol building. She is the legislative assistant for Congressman Mike Honda. She's worked for the congressman for 7 years in both the district, in his district, and in Washington, D.C. offices, and handles a wide array of issues, including health care, transportation, labor, agriculture, family and poverty issues. She's a graduate of Princeton University and until moving to Washington, D.C., was a resident of the Congressman District. And with that, I will hand it over to Karina Dan.
Thank you so much, Priscilla. Thank you, and thank the Health Forum as well for helping to host this webinar. I think it's always wonderful to get information about hepatitis B out to folks in the community to get them more involved. And so my goal is, if you could go to the next slide, to just provide an overview of hepatitis B virus and how it really impacts Asian American, Native Hawaiian, and Pacific Islander communities as much as possible with the data we have, and then to briefly talk about hepatitis advocacy opportunities to lead into Doug and Bernadette's presentations. Next slide, please. So hepatitis B, I always believe it's important to understand that there are three most common kinds of viral hepatitis in the U.S. Hepatitis B is primarily spread through blood and blood-derived body fluids, so through the skin, across mucous membranes, and often does become a chronic infection. The great news about hepatitis B is that we have a very safe and effective immunization. The test for hepatitis B is a blood test, although there are several different results that folks usually get when they order a hepatitis B panel. It's a fairly simple test to do with just a blood draw, and hepatitis B in general is very preventable. So that's the good news. If you compare it to hepatitis C next to it, hepatitis C is almost always spread through blood exposure and not so much through sexual exposure. And hepatitis A, on the other side, is really spread fecal-orally from contaminated feces. The good news with Hep A as well is that we have a vaccine. Right now for hepatitis C, there is no vaccine, so hepatitis B is a little ahead of the game in terms of being able to be very effectively prevented. Next slide, please. Hepatitis B transmission is very, hepatitis B is a very transmissible virus. It's about 100 times more infectious than HIV. It can live outside the body for up to 7 days and is very easily spread sexually through unprotected sex, parenterally, which is right into the bloodstream through needle sticks or IV drug use or blood transfusions before they were being screened, and perinatally from an infected mother to an infant at the time of birth. All of those modes of transmission for hepatitis B are very efficient, and so it is truly wonderful that we have tests that can determine if somebody's been exposed to hepatitis B as well as a very safe and effective vaccine. Next slide, please. So the good news is that most people with chronic hepatitis B don't have symptoms. But on the flip side of not having symptoms is the fact that about 65% of people with chronic hepatitis B are unaware that they're infected. When people do have symptoms, when they have acute hepatitis or a new infection with hepatitis, some of those symptoms are listed in the bullets below. But for the most part, when we see people with chronic hepatitis B, most people don't have any of those symptoms, and so they're unlikely to try to get tested for hepatitis B, and they're unlikely to seek care. Next slide, please. So in terms of hepatitis B in the U.S., and unfortunately this slide stops at 1995, but you can see that over the past few decades, we have actually had a real reduction in hepatitis B infections in the U.S. So these are new infections. They're more than 50% reduced from the high point in about 1985, and a lot of that is because we began screening pregnant women and preventing perinatal transmission of hepatitis B in the U.S. We have a great vaccine, as I've mentioned before. And there are some other things that have been done in terms of outreaching to very specific populations like men who have sex with men, healthcare workers, and injection drug users that have also helped with the decrease in new infections of hepatitis B. But in terms of Asian American, Native Hawaiian, and Pacific Islander communities in the United States, we see a different picture because they're suffering with chronic hepatitis B and not acute hepatitis B. So on the one hand, we've got fewer new infections. On the other hand, we still have a lot of people with chronic infection. Next slide, please. Next slide. Great. So to put hepatitis B in perspective, as Priscilla said at the beginning, hepatitis B is the most common bloodborne infection on the planet. Roughly 2 billion people on the planet have ever been infected, and of those, 350 million are chronically infected with hepatitis B. We're seeing millions of new infections annually, and it is estimated that about 1 million people die every year from hepatitis B. That said, the surveillance or the epidemiology of hepatitis B, the data that we have is not as good as we'd like it to be. And that data in the United States is also not as good as we would like in order to really understand the hepatitis B epidemic. But about 12 million people in the U.S. have ever been infected with hepatitis B, and we estimate that 1 to 2 million people are chronically infected in the U.S., with an estimated 43,000 new infections every year, and roughly 5,000 people dying every year from hepatitis B. So because most people don't have any symptoms, and also because of some of the stigma attached with having a chronic infection, hepatitis B is commonly known as the silent killer. Patients don't have symptoms. Often patients don't talk about hepatitis B either. And that has, it is true that it's one of the most prevalent infectious diseases, but when we don't talk about it, when we don't get patients diagnosed, then hepatitis B leads to cirrhosis, to liver failure, and liver cancer. And we do have treatments for hepatitis B which can prevent cirrhosis, liver failure, and liver cancer. As well, when we identify folks who live with someone with hepatitis B, we can get them vaccinated to prevent infection, hepatitis B being transmitted. So there are definitely great ways to prevent cirrhosis, liver failure, and liver cancer by preventing hepatitis B and by identifying patients that have Hep B and getting them into care. In terms of acute hepatitis B or new infections, adults who are infected with hepatitis B, for the most part, their bodies are naturally able to fight off the infection. They get rid of the infection, and they no longer have hepatitis B. So most adults, if they're infected, go on to resolve that infection and be hepatitis B virus free for the rest of their life. Only about 1 out of every 10 adults who gets infected develops a chronic hepatitis B infection. Unfortunately, the opposite is true for infants. So perinatal hepatitis B, about 9 out of 10 infants who are infected with hepatitis B never get rid of the virus, and they do develop a chronic hepatitis B infection. And those infants, because they're infected at birth, then have a lifetime of chronic liver infection, and their chances of developing cirrhosis and liver cancer are much greater because of that lifelong infection. Next slide, please. So hepatitis B in Asian Americans, I think Priscilla also mentioned earlier that Asian Americans account for more than half of the chronic hepatitis B cases in the United States and half of the deaths due to hepatitis B in the U.S. So compared to non-Asian groups, or the total number of people infected, in the U.S. about 0.5% of all people have chronic hepatitis B infections. And in comparison with that, in the Asian community, it's an average of about 7% chronic infection rates, which is 14 times greater. And that can range between 3% up to about 15% chronic infection rates. Those rates really vary by country of origin. So we've seen rates as much as 13 times higher for chronic hepatitis B in Vietnamese Americans, 8 times higher in Korean Americans, and 6 times higher in Chinese Americans in terms of liver cancer. But those are very similar to the rates as well for chronic hepatitis B infection if you compare that with the general U.S. population. Next slide, please. So when we look at what is currently being recommended, how are we identifying patients? Well, the CDC has recommended hepatitis B testing, and these recommendations came out in 2008. So hepatitis B testing is recommended for anyone who has any group that has greater than 2% prevalence, and that includes almost everyone who was born in Asia and in Africa. So immigrants from all over Asia, immigrants from all over Africa are recommended to be tested for hepatitis B. All pregnant women are recommended to be tested for hepatitis B because we can prevent perinatal transmission from an infected mother to the infant. And then once the child is born, it's recommended that that infant be tested for hepatitis B as well. Dropping down to household and sexual contacts are also recommended to be tested because hepatitis B can be transmitted among household contacts. And anyone with evidence of liver disease should also be tested for hepatitis B because if hepatitis B is the cause of the liver disease, then there are some things we can do to help prevent progression of liver disease. Next slide. So I wanted to let this group know about the Institute of Medicine report, which was published in January of this year, which really speaks to elimination of hepatitis B virus transmission as well as care for people with chronic hepatitis B. So the Institute of Medicine convened an expert panel which looked at all the data on hepatitis B and hepatitis C to try and develop recommendations. Those recommendations really fall in line with much of what the community has been asking for many years. And the full report is available online at www.iom.edu if you want to download either the executive summary so that you can see the full list of recommendations. It's up there. So I pulled out specifically those IOM recommendations that are meaningful for Asian American, Native Hawaiian, and Pacific Islanders. One thing that's very clear from the IOM report is that we don't have the kind of data. We haven't been doing the kind of surveillance that we need to do in order to understand who we should be testing within specific subpopulations of Asian communities. So we know that there's a range of chronic infection rates from 3 to 15%, but with better surveillance, we should be able to better target our screening efforts. And so one of the IOM report recommendations is that targeted active surveillance should be conducted in populations that are not fully captured by core surveillance. Right now, what the CDC is doing is looking at some more general data, but those general data don't always capture hepatitis B rates among specific populations that many of us would like to be reaching out to. The IOM report also recommends increasing knowledge and awareness about chronic hepatitis B, and many of you are familiar with the fact that healthcare and social service providers actually don't always know a lot about hepatitis B. They don't know who to screen. They don't know then once they find somebody who's positive what kinds of counseling and management and care for those individuals. So we really need much better hepatitis B educational programs for healthcare workers and social service providers, but also among at-risk populations and to increase general awareness in the population, because again, about 65% of people with chronic hepatitis B don't have any idea that they're chronically infected, and so we really need to get a lot more education out into our communities. IOM recommends some immunization strategies, vaccinating infants who are born to chronically infected women and giving them hepatitis B immune globulin, which by and large is happening, although not completely. We still have between 500 and 1,000 infants who are perinatally infected with hepatitis B every year in the United States. And the fact is that we can prevent perinatal transmission if we work a little bit harder. I'm sure that we can eliminate perinatal transmission of hepatitis B in the U.S. Mandating hepatitis B vaccine for young kids in order to get into school is another recommendation from the IOM report. And then catching up with adults at risk and getting them vaccinated to prevent transmission among household members and sexual contacts where it can be prevented because we have a safe and effective vaccine. Next slide, please. So in terms of chronic hepatitis B services, IOM also recommends, again, providing hepatitis B services, testing and screening and vaccination for targeting foreign-born populations. Again, because so many people immigrating to the United States are coming from countries where the chronic hepatitis B rate is very, very high. Our goal is to test those individuals and get them into care, find people who are infected with hepatitis B and test their household contacts so that we can get them into care as well. Recommending that the CDC should provide additional resources to perinatal hepatitis B prevention program coordinators. Again, we can prevent perinatal hepatitis B transmission, and we can better care for women who are chronically infected as well as their household members. And lastly, HRSA, the Health Resources and Services Administration, should provide adequate resources to community health centers where so many people do seek care. And we'd like for HRSA to take leadership on this issue and develop a better program and guidelines for screening patients and identifying people with hepatitis B and C and getting them into care. Next slide, please. So in working with Bernadette and others in the hepatitis community on HR 3974, some of the challenges that we've come up with are that there's really a dearth of data. So there's nowhere near the data that some other disease states have or that the legislators really want to see to support increasing federal funding, to support more legislation to improve services for viral hepatitis. Another major problem that we have is that there hasn't been a lot of community action or community voices. We're really, truly only now in 2010 starting to get involved and get people up to the hill and identify what legislators may be champions and get communities mobilized to talk with those champions. Those are the kinds of things that have worked for example, people with HIV who've gotten a lot of legislation and funding for HIV. For hepatitis B, the community has been so quiet that people on Capitol Hill often feel that it's not a problem, and so they don't need to do anything about it. The other problem is that there's a lack of uniform guidelines on care and treatment. There are a number of recommendations out there. Because the treatments are changing, those guidelines have been changing along with the available treatments. The screening guidelines just changed in 2008, and it's a challenge for providers as well as the public and legislators to keep up with exactly what the best method of providing care and treatment to people is. Those are our main legislative challenges. Next slide, please. Currently, we've been working on HR 3974. Historically, there was a hepatitis B bill that was separate and a hepatitis C bill that was separate. But last year, the community, the hepatitis B advocates and the hepatitis C advocates came together to draft this new piece of legislation. And we're really excited about it. And I know Bernadette is going to talk more about that in a few minutes. But the other initiative that advocates have been working on is to get more funding, usually asking for additional money for the Centers for Disease Control, the Division of Viral Hepatitis, which has actually seen a decrease in funding from a high point of $25 million in 2001 to a low point of $18 million in 2010. So currently, we're hopeful that in 2011, in that budget year, that we'll have an increase up to $19.3 million. But that level of funding for a national program doesn't fund testing. It doesn't fund a fully operational surveillance section. And it certainly doesn't provide for care or for treatment for people with chronic hepatitis B. Next slide. So what are we asking advocates to do? This is sort of new for many hepatitis B advocates, but we really need to work on increasing congressional support. We sent out action alerts at least a couple of times this year, asking folks to call their legislators and let them know how important it is that they co-sponsor the viral hepatitis bill. Making in-district visits to educate legislators and their staff work pretty well. And then talking about HR 3974 and the need for funding when you go for in-district visits, when you call their offices. And they like to hear your story. They like to hear, the people that you see or the people in your family or in your community that are impacted, that are infected with chronic hepatitis B, and hear a little bit about the challenges that they have for getting care and services. And then when you're talking with staffers or members of Congress, certainly making the ask to co-sponsor HR 3974 and to increase at least to $50 million the budget for the CDC Division of Viral Hepatitis. Next slide, please. And timing really is important here. We've got in 2010 the Institute of Medicine report with their recommendations, which do fall in line with the community requests and, for the most part, the sections of the bill. We also have an administration now that is open to Asian American, Native Hawaiian, and Pacific Islander issues. For the first time ever this year, or last year, our president said hepatitis B, and before that he said hepatitis C. So he knows that hepatitis is an issue, and it's up to us to continue to work with the administration to really address hepatitis B. And now that we have the advocates working together, now is the time, and you can join the National Viral Hepatitis Roundtable as well as an organization to receive their action alerts and participate more in hepatitis advocacy. Next slide. So we can eliminate hepatitis B transmission in the United States, especially if we have increased community participation. And I believe that that's my last slide. And I know that Doug and Bernadette have some additional information and model programs and legislation to talk about. Thank you.
Great. Thanks, Karina. Doug, I'm going to hand it over to you.
Yeah, thank you. So thanks to Karina for the nice update and background on hepatitis B science and epidemiology, policy, advocacy. I think it sets a good stage to talk about, how we take what's known and try to do something related to hepatitis B at a community level. And that's what I'm going to talk about, a little bit about what we're doing here in the Phoenix area. And hopefully we'll have a chance to hear during the question session from some other folks who are doing similar work in other areas. So I want to start real briefly with, next slide, just a little bit about us. We're a nonprofit agency. We are here in the Phoenix area. We're health focused, so we have a mission to improve the health of Asians and Pacific Islanders. We're involved in lots of different health areas, hepatitis B in particular, but tobacco, breast cervical cancer, emergency preparedness. I sometimes describe us as a health department for Asians and Pacific Islanders because of the various things that we do in public health. And then types of activities we're engaged in, educational workshops, screening clinics, which I'll talk about, research, advocacy, and referral. Also, we have, just for sake of magnitude, we have 6 staff and a budget of about $500,000. And we were established in 2002. So we call our hepatitis B program Jade Ribbon Arizona. It basically got started in 2004. We held a community summit. We brought out Dr. Sam So from the Asian Liver Center in Stanford and basically did a sort of big splashy meeting for the Asian Pacific Islander community. Sort of jump-started us, I think, into our hepatitis B work. And we held our first hepatitis B screening event in June 2005. That was actually at we're not a medical organization, so we have to find places to do events. And at that point in time, we were using a community health center called Mountain Park Health Center to host the clinic. The purpose of the program is to decrease preventable morbidity, mortality due to chronic Hep B infection. Resources, I think we probably have more than most. We've been pretty lucky. We do have a state contract to do the education and the testing. We've had that for the last, it's probably getting close to 3 years. We get support through Health Through Action. We're one of the grantees of the Health Forum for that Kellogg project, and we get small corporate grants to subsidize the testing. So our approach has really been fourfold. We've been pretty active in terms of assessment and trying to understand, I think, the environment in which we're operating related to people's perceptions about hepatitis B, and certainly the infection rates, which I'll talk about, public education, provider education, and then doing a screening, ensuring that people have an opportunity to get screened and vaccinated. So assessment, we've actually been quite active in assessment. We've gotten data from the state health department, basic reportable disease data. How many chronic hepatitis B cases are reported, what's the race ethnicity profile. Same thing for perinatal cases, and found out that, not surprisingly, that Asians and Pacific Islanders are overrepresented among people who are reported with chronic hepatitis B, which has been important. We've obviously been able to leverage that into resource. We've conducted randomized phone surveys in the Chinese, Korean, and Vietnamese communities, asking a bunch of questions, but adding some questions about whether people have ever been tested for hepatitis B and whether they've ever been vaccinated. In those 3 communities, people say about 50% say they've been tested for hepatitis B. Done some focus groups, asked questions around barriers to hepatitis B screening and vaccination, more of a qualitative approach, and even approached the Medicaid agency to see whether Asian Pacific Islanders are receiving hepatitis B screening at any greater or lesser rate than other groups. And we found out actually they get screened about the same rate within the Medicare program. Public education, we've been doing lots of different things. So articles in the ethnic media, we have about 3 Chinese newspapers, 2 Korean newspapers, a couple of radio stations, Vietnamese and Korean radio stations, and several other outlets in the Asian Pacific Islander media. So when we can, we place articles about hepatitis B and the risks. We do workshops. We haven't had a lot of success, I think, with just doing come one, come all, hey, hear about hepatitis B. So what we've done more of is gone into groups. For instance, here in Phoenix, we have a Chinese American Citizens Alliance group. Get 10 minutes on their agenda and try to give them a quick 10-minute update about hepatitis B, and I think that's been a little bit more successful for us. We do educate at our screening events, so when people are coming in to get tested, we try to make sure they walk out educated about hepatitis B, that they don't just stick their arm out and get stuck with a needle without really knowing what's going on. We would love to have folks walk out and be sort of our advocates, our evangelists, and have them tell 5 more people to get screened, whether it's at one of our clinics or in a private doctor's office. We have a table exhibit that we use at health fairs and cultural events. We're also looking at adding hepatitis B as one of our lay health worker topics. We probably should have done that a long time ago, but I think getting the word into communities through lay workers is an approach that can be very effective. Next slide. So one of the things that we've done as well in terms of the media, the photo is a variety of people from the local ethnic media. We put together a luncheon, invited basically everyone in the local media, the ethnic media, and basically got everyone to come. It was probably the free lunch, but they showed up. We managed to talk to them about hepatitis B, ask them for some free ad space, which they gave us, and we ran a series of articles about a particular person and their story related to hepatitis B, so that was very successful for us. Next slide. So provider education is another approach. It's a very important component of a program, I think. We have been trying to do provider education largely in partnership with pharmacy reps, the folks who manufacture Hep B-related treatments. Are more than happy to host a dinner if we can find the providers, mostly physicians, to come and attend. So we've actually helped educate a lot of folks through that method. Try to sneak in on other speaking opportunities. I've had a chance to go and speak to various physician groups about hepatitis B as well. We post articles in health plans and newsletters, helpline newsletters, provider newsletters, anywhere where we think there's going to be a physician audience or a provider audience. And then we're also considering, we've been talking about it for longer than we should, a mass mail-out of a Hep B algorithm. It actually it comes from, I think it's the San Francisco Hep B Free program. They produce something that's very nice. It's a 2-sided plastic in lamination, very simple directions to physicians about how to screen and what the screening results mean, and a little bit about treatment. So we need to get going on that, but that's, I think, an important piece as well. Next slide. So the screening, the actual clinical testing, like I said, it started in June 2005. We did kind of a come one, come all screening event at a community health center, advertised it in the local ethnic papers, had a pretty good response, and have since been doing those types of screenings about quarterly ever since. We eventually expanded testing to other sites. We went into churches. We go to festivals. We were at a Pacific Islander Easter festival on Sunday doing screening. We've been to the universities, community centers, the Indo-American Community Center for South Asians and Filipino community centers. In 2009, we started a new program called on-demand testing, which allows an individual to go to one of the 37 different Sonora Quest test sites to get screened. We pay the cost of the screening. They just have to register through us. And then important to note that at any of our screenings, we provide at least a first dose of Hep B vaccine, and then try to help folks that are susceptible through their antibody tests, which we do run, to get their second and third dose. So I'm going to move quickly here because I'm probably running out of my time. So just a little bit about the screening data in terms of who's been screened. You can see that most Korean and Chinese are the most screened, and then Vietnamese below that. Next. And this is interesting to me anyway, the different rates of positivity. We found 12% among Vietnamese and about 7% among Chinese, and lower among Asian Indians, Koreans, and Filipinos. To me, as an epidemiologist, that suggests that we need to make sure we're outreaching particularly Southeast Asians. Next. And then a little bit of data about where we've been screening. And since we sort of ramped up our faith-based church screening, that actually now is the location where we've done the most screening. FQHC in the middle, by the way, stands for Federally Qualified Health Center, or Community Health Centers. Next slide. So lastly, just a couple of issues. Of course, when we find people who are chronically infected, we have folks on staff contact them and help them find a medical provider if they don't have a provider and if they don't have health insurance. I actually just chatted with staff before this webinar, and they seem to think that that's working pretty well, even for folks who are low income, uninsured, that the referrals seem to be working, although I put in parentheses look-back study because I think it'd be interesting to go back and see where some of the people we tested a couple of years ago are in terms of their health care. A little bit worried about message fatigue. We've been using some of the same ads, and we don't really have a big marketing campaign. So some of our testing has been dropping off just a tad in terms of our Come One, Come All community health center testing. We're getting the sense that the people who want to get tested have gotten tested. We need to be mixing our messages and getting some more interesting messaging and maybe a larger campaign going. And lastly, program sustainability, always a problem. We're not certain that we're going to get funded again through the State Health Department for the upcoming year, so we have to worry, of course, about where the funds are going to come from in future years, which is a problem with lots of different. And then lastly, it's just the ad that we've been using for a while. I thought I would put that on here just so you could see it. This is the ad that we place, and we get a certain number of people who come to every event, but like I said, I think we need to be looking at slightly different messaging and approach. So that is about it. Thank you very much.
Thanks so much, Doug. You guys have been busy. So with that, I'm going to hand it over to Bernadette from Congressman Honda's office.
Hello, everybody. I just want to make sure you all can hear me. Priscilla?
Yes.
Okay, great. Sorry. So I just wanted to check because I got disconnected a couple minutes ago. So I am here to give you a bit of a background on H.R. 3974, the Viral Hepatitis and Liver Cancer Control and Prevention Act of 2009. And next slide. I'm going to go ahead and give you a brief overview of the history of the, an overview of the bill, and in conjunction with this, a bit of an oral history on how the bill came about. Basically, Congressman Honda had carried a standalone hepatitis B bill along with Charlie Dent of Pennsylvania, and Mr. Ed Towns had carried for a long time the hepatitis C bill. And when I came on board, we were starting the conversation with advocacy groups to bring the two bills together and meld them, because we felt at a staff level, and then when as you spoke more with advocacy groups, we felt that there were a lot of similar policy objectives for both B and C that could be pursued in a single bill while still addressing the individual concerns of the B and C communities. So this is a brief overview of the bill. This is taken from a summary document that's available through the groups, or if people are interested, from me. And you can read the bill in detail on thomas.loc.gov if you're interested in the legislative details. But basically, H.R. 3974 touches on it vastly expands the authority of CDC to address, well, not just CDC, but HHS, to address the chronic hepatitis crisis in the country. It touches on education and training, so we take care of the healthcare professional education and education of the public part, disease control, so it promotes and supports state and local and tribal programs for testing, counseling, and referral for management, surveillance, establishment and maintenance of state surveillance databases for B and C, immunization. It expands the current vaccine programs to all susceptible adults, high prevalence ethnic populations, other high-risk groups. It supports the adult viral hepatitis coordinators. It addresses the issue of underserved and disproportionately affected populations. In case of B, the Asian American Pacific Islander community. In the case of C, the African American community, for example. Medical referral, it supports referral of persons infected with or at risk for B and C for alcohol and drug abuse treatment and for ongoing medical management. And then finally, research. So it authorizes programs and approaches that are really, the community, when we worked on this bill together, really looked at making the response a broad-based federal response. And in follow-up conversations with IOM, this bill that was crafted by the community dovetails quite nicely with the recommendations made in the IOM study as to what the federal response needs to be for to address the crisis in our communities. Next slide, please. So it was currently the bill as it stands has, and I'm sorry, the first bullet point on here is incorrect. We have 31 co-sponsors and not 26. Out of the 31, we have a strong bipartisan 6-member core of supporters who've really stepped up and taken more of an additional leadership on the issue. In addition to Mr. Honda's office and Mr. Dent and Mr. Towns, Mr. Gao from Louisiana, Hank Johnson, who recently came out publicly as a person who is fighting hepatitis C, and Rep. Cassidy, who is a hepatologist, have all come out and really taken leadership roles in speaking out on the issue and signing on to and heading up letters from the rest of the from multiple members on funding for viral hepatitis related activities at CDC, presidential proclamation request, a World Hepatitis Day resolution. So these core members of these core supporters, this doubles essentially the number of people who were in Congress, who were active and engaged in raising awareness, and that's really what is needed. Not only are they bipartisan, but they are knowledgeable and committed to the issue. And right now we have a hearing that's going to be scheduled in the Committee on Oversight and Government Reform, and APIAHF and the other members of the Viral Hepatitis Roundtable have been in communication with that committee staff on the upcoming hearing as well. So that's very exciting, and so that's what the current status is of the bill. And I just want to back up a little bit and talk about what the difference is between the authorizing of programs in the bill and then the appropriations process, actual funding for activities that could be authorized if the bill gets passed, or current activities that we're looking to support for additional funding in current appropriations bills. So next slide. The programs that I talked about, all of the education, the training, a couple of slides back, all of those would be authorized, and there's two parts of the process. The first is authorization. Authorization establishes, continues, or modifies agencies or programs. And even in the case where you have an authorizing bill that says that, for example, in our bill, $90 million is authorized to be spent in the first year, and then it goes up to $150 million is authorized to be spent in the 5th year of the bill. That does not guarantee that such amounts will be made available. It's just giving permission to Congress to appropriate that amount every year if they can. That brings us to the second point, which is appropriations. So appropriations measures may provide funding for agencies and programs previously authorized. So this is basically the yearly appropriations bill are what fund the activities of the federal government. So the CDC, HRSA, all of HHS, all of the different agencies under the Department of Labor or the Department of Defense or the Department of Transportation. All of those are funded through annual appropriations bills. So there are 3 kinds of appropriations bills. First kind is the regular appropriations that we're discussing. Fiscal year 2011 is the regular appropriation for next year that will fund all of the activities for CDC, for HRSA, for NIH, for all of those other programs under HHS. There is a continuing appropriations bill which usually gets passed in the case that Congress can't necessarily agree on the regular appropriations bills, and that can continue funding from, say, FY 2010 levels through FY 2011. So they can be either short-term, a couple of months, so that the government can continue to operate while the regular appropriations bills are worked out, or they can be a year-long continuing resolution, which basically just goes ahead and extends the funding level from a previous year into the next fiscal year. And then the third kind is a supplemental appropriations bill, and that's kind of like an emergency fund. In the middle of the year, we've traditionally used them for things like funding activities in for Department of Defense related activities, sometimes for jobs or for funding to make up for shortfalls in Medicaid in different states if they run out of money halfway through the year. So those are the 3 kinds of appropriations bills, and the kind of advocacy that the Health Forum and the other members of NVHR are usually engaged in is the regular appropriations process. Happens every year. It makes funding available for activities in HHS, and it's the sort of the second part of the process, sort of aside from the authorizing focus. It makes funding available for current activities that they're already engaged in at the Division of Viral Hepatitis. Next slide. So Karina had mentioned some of the other advocacy efforts that we've worked on with other offices, presidential proclamation, advocating funding in the annual appropriations process. The other things that she's mentioned, briefings and office visits to build support for the authorizing bill. And then the other part of that that's really critical is the building of the community partnerships and the advocacy and the concerted advocacy between the B and C communities to come to Congress in an organized way, because that kind of creates an advocacy echo chamber. When you work, when you have partners like NASDAD and you have other partners on, who are coming and echoing the concerns of your group, then members of Congress don't hear about viral hepatitis just from this group over here or that discrete group over there. They hear it from multiple sources, and so it creates sort of an advocacy echo chamber that really raises the issue above sort of the level of other concerns that other people are advancing. You can also advocate on related issues, not just yes, we want to educate people about the importance of the bill or educate people about the appropriating request, but you can also educate people about data collection. The importance to improve our data collection pieces, hospital-acquired infections, maternal and child block grant funding. There are state-level efforts. In California, Assemblywoman Fiona Ma has a particular interest in this and has been very effective in raising the issue to California. So, basically the combination of the community coming to Congress in a cooperative way to work together in partnership between themselves and with NASDAD, with other constituencies who are interested in the issue and in related issues, has built our efforts from a couple of members to 6 core and 31, supporting, and then also, the administration is taking an interest now, and CDC is engaged, and so we've really started to sort of take hold. And this process is a long one, but it's critical to have the kind of engagement from the community to come to Congress and to educate the members about the details of the disease, but also to be organized in their approach so that the members, when they hear and they say, what can we do to help, you can point to the bill, you can point to the appropriations request, and you have that to focus their energy on. So I want to thank the Health Forum for having this webinar, and thank Karina, and thanks for letting me present, you guys.
Great. Thank you, Bernadette. And so, folks, I realize that we are running a bit behind time, but each of the speakers has agreed to make themselves available for a few more minutes past the hour if you have questions. So if you look to, I think for most people, the control panel pops up on the right, but there is a question box where you will be able to type in your questions. And so as people do that, I want to remind everyone that this is being recorded and the slides will be available. So once we have everything put together and made available on the website, you can view everything and listen to everything that's been presented today. And I also wanted to, as people are typing in their questions, address some of the questions that folks submitted beforehand, which we've organized into three broad categories. And so the first question actually addresses a number of questions that we received that are really clinically based. So they related to screening, vaccination, and treatment of hepatitis B patients. So I'm hoping that, Karina, if you can draw on your experience as a nurse and an advocate who has worked with patients and providers, I was hoping you could comment on any strategies and interventions for working with Asian American, Native Hawaiian, and Pacific Islander individuals and communities when it comes to treatment, screening, and vaccination.
Great. Thank you, Priscilla. I know we did get a number of questions on interpretation of screening tests. They can be very confusing. In general, as most people who've done hepatitis B screening, a surface antigen positive indicates chronic infection, and an antibody indicates that that person has immunity to hepatitis B. Whenever I've asked the liver specialists what to do with results that seem conflicting or results on the same patient that come back different a second time, I've always been recommended to refer every one of those to a specialist. And while I know there aren't as many specialists, hepatologists, as we need in the country, many of them are happy to sort of be supportive and provide technical assistance for groups that are doing outreach and education in the community. And I would recommend that groups that need to identify or find a hepatologist or a gastroenterologist who knows about hepatitis in their area can visit the Hepatitis B Foundation website, which is simply hepb.org, so HEPB.org, and they have a physician finder right on their website so that people who have those kinds of questions, to vaccinate or not to vaccinate based on test results, if there's any kind of confusion, it is actually best when you get conflicting test results to go back to the specialist to ask whether that person should be screened or vaccinated, and often it's that the specialist needs to see them. There are a lot of clinical issues, and I know a lot of the folks on this call are very involved in that kind of thing, and we really wanted to try to stick with, just an overview of hepatitis B, and then really talk about advocacy and community action. So in addition to hepatitisb.org or hepb.org, another great website that has print-offable fact sheets is HBVadvocate.org. So those are the two websites that I wanted to share today, HBVadvocate.org and hepb.org. Both have medically reviewed information that advocates and health professionals and patients alike can all use.
Great. Thank you, Karina. And I did receive a request to speak up. So if folks are still having problems hearing us, please let us know. So there were also some questions about the availability and the distribution of funding on both the federal and local levels. Bernadette, I was hoping you could comment on,
Sorry, can you repeat that again?
Sure. Questions about the availability and the distribution of funding on the federal level, if you could provide that perspective, and then Doug or Karina, if one of you can comment on community-based approaches to getting resources and funding.
And pardon me if I cough. I'm getting over a cold, so I'll try not to cough into my phone. But yes, the funding level, as Karina mentioned, has been difficult. It's been difficult to increase funding available through CDC's Division of Viral Hepatitis, which is really kind of the only direct, and is really the only agency or office dedicated to viral hepatitis. So we have, Mr. Honda is on the Appropriations Committee, and this has been a priority for him every year to try and increase the funding level. And we've gotten small increases over the years, but it really has not reached the level that we think is necessary. And additionally, there are some questions about the distribution of funds within the agency, between B and C activities, that sort of remain to be discussed and addressed. But certainly, that core group of 6, and then the other 31 folks who are on the bill, on the authorizing bill, we've done a tremendous amount to reach out to them to try and get their support to increase the funding for the current activities that the division is engaged in. And so I think that the next step to this is, reaching out to the administration, prior to them putting together their federal, prior to the president putting together his budget request for the next fiscal year, to sort of indicate or encourage a request, an increased budget request, because that's what goes along. That request for an increase from the president certainly helps bolster activities that Congress, requests that Congress make to the Congress people make to the Appropriations Committee. On the state level, I don't, other than the money that flows through, say, block grant programs that could be used for viral hepatitis, I don't know as much about the availability there. Certainly, there's a new emphasis on prevention, and there's new funding for prevention that's made available to CDC through the health reform bill that was recently passed. And so I think that there is some opportunity there for advocates and for interested members to sort of weigh in at appropriate times when the regulations are being written, when as the reform bill is implemented. So I think that the short answer is that there is interest and support for increasing the amount of funding on Capitol Hill, and the difficult part now is educating more of the senators about the importance, so that you have the House and the Senate equally engaged in the effort to increase funding for the division.
Yeah, this is Doug. Maybe just a quick comment on state funding. One of the things that we did actually before I started as executive director was to go to the state health department and basically just ask for money for the issue. Now, that didn't work, but not initially, but what it did do is made the issue visible to them, and Karina had talked about people needing to speak out and advocate. So that actually started a series of discussions and ended up in a hepatitis B task force that created some of the data that I had mentioned previously, and eventually led to a grant from the state health department. And I'm not saying that that's going to happen every time, but unless your state or your county health department is aware that it's an issue in the community, they're obviously not going to do much about it. So I think even just doing a bit of an ask at a county or state health department is something to consider.
Absolutely, Doug. This is Karina. I think asking, not only for funding, but also, when you're able to vaccinate individuals at risk, sometimes states may be able to make vaccine available. Sometimes states can make testing accessible through the state lab. Obviously, those resources are limited, and especially with some of the economic stuff that's going on now. But there are many ways that you can try to leverage, resources out of state and local health departments. And like you said, if you don't ask, they'll never know that you need it. Recently in Maryland, we were able to get more vaccine for Asian Americans and other adults at risk because we brought it to their attention that that wasn't on their priority list for the vaccine, and they hadn't been able to do it before, and now they can.
And just, this is Bernadette again, just to illustrate, that even when states do act on their own. California, I recently met with the California Director of Public Health, Dr. Horton, and when I mentioned that we were interested in viral hepatitis, he said, "Oh, well, the California, we looked at the IOM report that came out, and we developed a California blueprint for action." And then I mentioned that Assemblywoman Fiona Ma is particularly interested, and he didn't know that, and so I connected the two offices together on this. So, even in states that are a bit more ahead of the curve, like California is, they may still not have that connection to a local assembly member or a senator or a state, or community-based organization to get that information out. So,
good point. Thank you, everybody. So we also have received some questions relating to data and how advocates can actually find ethnic-specific data. And I also see a couple questions in the question box that refer to specific statistics that were in the presentation. So if I may, the speakers who did have data in your presentations, since the webinar will be made available, is it okay for folks to follow up with you individually with those questions?
Yes, definitely fine by me.
Okay.
Yes.
Great. So, so for folks who had a very specific question for one of the speakers, you can follow up with them, and we'll make their contact information available. But secondly, if I don't know if perhaps Doug and Bernadette or Karina, if any of you have any suggestions for places to actually find some of the data that's commonly looked for by Asian American, Native Hawaiian, and Pacific Islander advocates.
Yeah. Well, again, the approach we took was to seek whatever data was available from the state and county health departments. I think that's a starting point. It's probably not going to be disaggregated, so you're just going to get sort of a lump Asian Pacific Islander prevalences related to reported cases of hepatitis B, whether they're acute or chronic. That was our starting point. We also, as I had mentioned, kind of did our own. We weren't satisfied with that data, and we needed to dig one or two levels deeper, so we ended up doing our own studies, which, to be honest, is somewhat expensive and time-consuming. We think it's well worth the effort, but gathering your own data is another alternative. That's probably not that helpful, but that's what we did.
This is Bernadette. And this has actually been data collection in general, not just on health issues, but on a whole other range of issues. Has been a big issue for Mr. Honda as chairman of CAPAC. As everyone knows, this census buildup and has been, a lot of it has been about properly sampling and making sure you have enough data on the right communities and making sure that everybody's counted. And so this is an issue from census to small business issues, housing, data on housing and foreclosures. All of these, including healthcare, usually don't disaggregate for there's just no way that there's a way to do it, but they don't disaggregate to reflect the diversity of the API community. So this has been an issue that Mr. Honda has raised continuously over the last year. The Senate bill had some fairly good data collection language in it. The Senate Health Reform Bill did. We have also put in report language on data collection in the past in the appropriations bills. Mr. Hahn is a member of the Congressional Tri-Caucus, which is the Black Caucus, the Asian Caucus, and the Hispanic Caucus working together to promote and work on issues that all three are concerned about. And so data collection has been one of those issues that we've tried to raise up as an issue. So there are certainly people in Congress who are aware of this and trying to fix the problem. And I think we've had some limited success, but certainly we're always continuing to try and keep it at the forefront of all those discussions.
Mm-hmm. Yes, definitely data collection is one of those cross-cutting issues. Going through some of the questions in the question box, we do have a question about the impact on Native Hawaiians. Is there anybody who can speak to the impact of hepatitis B in Native Hawaiian communities?
Well, this is Karina. I have requested data from the Hawaii Department of Health. They have clearly responded that they are not able to do that level of surveillance for hepatitis B. I know that Dr. Naoki Tsai from Hawaii has has worked in Hawaii for a while on hepatitis B, and I believe that he found somewhere between 4 and 6% positivity among Native Hawaiians, but it was a very small sample. So again, we're looking at groups that haven't really been adequately screened and data sets that haven't been really well defined, unfortunately. So it's a lot of the work that we do in terms of trying to get a grasp of what prevalence of chronic hepatitis B is in specific groups is really partial data, and not always you can't always generalize it to even the larger subpopulation that you're trying to quantify, unfortunately.
Got it. Thank you. There are a couple questions that relate to advocacy strategies, so I'll just clump them together. But one of them is about, I think this one's for you, Bernadette. Are there any specific reasons why representatives would not co-sponsor a bill like this, and how important is it in the long run to increase the number of sponsors in terms of getting funding? And then another question that I think is directed to you, Doug, with regards to advocacy. This person would like to know, what exactly did you ask the media to print when you brought them together? Did you specify, particular statistics, where to get screened? What was kind of the type of information that you asked the ethnic media to address when you gathered them together? So Bernadette, if you can go first.
Sure. And the question was, how important is it to get co-sponsors, and why would they not co-sponsor? Well, some of the reason why some members might not co-sponsor is because we do authorize funding in the bill, and we do, expanding the authority and increasing the activities to the extent that we want will eventually, if the bill is passed and we fund them, it will cost additional money. So I think that some of the reluctance that members feel is related to spending more money in the future. So they might think, yes, this is an issue, but if they're deficit hawks or they're very concerned about cost to the federal government, they don't want to, even though this bill doesn't directly appropriate money immediately, it just gives the permission for the Appropriations Committee to appropriate that much money in the future. People still feel reluctant to sign on to a bill that would call for more funding for federal activities. That's usually the reason why people are reluctant to sign on. It's not the issue, it's the cost. And so that's why we've tried to approach that concern by pointing out the cost of not taking care of the crisis, of not having this sort of concerted federal response. And in terms of getting to sponsors, it doesn't help directly in that, you know, there's a certain minimum number and then we get a hearing or the bill gets passed. But it does raise the sort of profile of it when we go to the committee's jurisdiction and ask for a hearing, ask for them to consider the bill and bring it forth. It does move that process along faster. As far as getting more funding for the issue for current activities, it gives you more people to approach when you're sending out a letter like we did asking for increased funding in FY 2011 appropriations. So when you have more people asking for more money, then you have an increased chance that the Appropriations Committee is going to appropriate more money. It's not a guarantee, but it certainly helps to show that this has broad-based support and concern among members.
Right.
And then the question about media and what to print. We actually put a packet together. We had an ad that was announcing our new, I had mentioned our on-demand Hep B testing program. So we were specifically promoting and asking for sort of a media blast on this new program where people could go to any test site and get a free blood draw and a Hep B test. We also asked them to print a 3-part story that we had created around a person who had chronic hepatitis B infection, and trying to personalize the issue and drive people into either our on-demand testing or to our test events or to their private physician. So we had a bit of a strategy around what we wanted them to print.
Got it. Thank you. So we are way over time, and I apologize for keeping everyone so long, but I see that most folks are still have still logged in, so I think that speaks to the high level of interest in this issue. Unfortunately, we could not get to everybody's questions, but as I mentioned before, we will send out a follow-up email with the link to this webinar recording and the contact information for all of the speakers. So hopefully you can keep your questions in mind and reach out to the appropriate presenters with your questions and get them addressed in that way. So thank you very much for participating, and have a great rest of your day. Thank you. Bye.